بس في شيء قاطت يا بس بدي اعمل فول سكرين ما عم بقدر. خليني نشوف وين بدنا نعمل فول سكرين. لقيتها. اجيت الفول سكرين.
ايوه دكتور جون.
يلا. Okay, this is the topic. I'm بجرب شيل هاي. Okay, so we will be discussing osteomyelitis and septic arthritis. But the way we're going to discuss it, we're going to present these at the beginning. But at the middle of the lecture, we will be shifting to radiologic views. And this is the purpose, to ask the residents questions and how to describe an MRI, how to describe an X-ray, what should he look for. Usually, septic arthritis or osteomyelitis separately occur in the first decade of life, and osteomyelitis affects 1 in 5,000 children younger than 13 years. It is 2.5 times more common in boys than girls, and it involves the lower extremity far more than the upper extremity. Why? Because boys are active, they're playing football, they're jumping around, they sustain injuries, and we think that a good factor in the cause of osteomyelitis is partially trauma. Advances in antimicrobial therapy have decreased the mortality from 50% to less than 1%. يا جماعة, during the Second World War and before, there weren't antibiotics. Then when antibiotics became apparent, mortality declined. In the past, we used to treat them with immune blood. We used to give the patients immune blood to overcome the infection. The emergence of more resistant, virulent strains of bacteria has added complexity to the management of affected children. We are finding, due to antibiotics being given right and left, indicated or not indicated, we're beginning to realize that there's more resistance to treatment. We are harming ourselves by our own selves. Now, acute hematogenous osteomyelitis is the most common type of osteomyelitis. And what are the risk factors for developing acute hematogenous osteomyelitis? Diabetes mellitus, we all know that the resistance is low. The immune mechanism is defective. We know they have a poor soft tissues and a poor reaction to any inflammation or any injury. Chronic renal disease, hemoglobinopathies, rheumatoid arthritis likewise. They have a poor defense mechanism. Concurrent varicella infections, immune compromise in patients who have tumors. You're giving them chemotherapy. You're giving them radiation therapy. The defense mechanism is poor. Healthy children are often affected nowadays. When we want to describe an infection, we can say whether it's acute, chronic, or in between, subacute. Usually, acute infections are hematogenous, and they occur less than 2 weeks of onset after some time. 2 weeks. The timing given for it is 2 weeks, and it's a pyogenic infection. Subacute are non-pyogenic, and chronic infections are more than 3 weeks, and we will be discussing about it in detail. The pathoanatomy of acute osteomyelitis. Most cases of acute osteomyelitis are hematogenous. It comes from a source in the body. It comes from a carbuncle. It comes from a tooth which is infected. It comes from any retropharyngeal abscess with bacteremia occurring, followed by septicemia or localization of an area where there is pore resistance and probably having a minor trauma that led to this infection. We know that osteomyelitis occurs in the metaphysis. Why? Because it has a high circulation, it has a sluggish circulation, it has an end circulation ending up in loops with eddy current, and it occurs in an area where the lymphocytes, leukocytes, and all the inflammatory processes are involved in growth, as I spoke to you about the dysplasias. So these are concerned with growth. So they are diverted from the source of infection. The organisms take advantage of this. In addition, any trauma to the area would irritate these vessels, would damage these vessels, and the organism can easily seep out of the vessel into the tissues. This stimulates inflammatory cells locally, and as a result, what happens? The osteoclast is activated, bone is destroyed, and the infection is wise. What do? The organisms create a protective layer, which is known as the biofilm or the cryoprecipitate, and prevent antibiotics or anything coming to fight them back. So you have a slow blood flow in capillaries of the metaphysis. These bacteria exit the vessel walls. And if a sufficient number of bacteria lodge in the bone, they overwhelm the local defenses, as I have already mentioned. And then infection sets in. And then it is our hell. We don't like to see infections in bone because there's a statement that says, once an infection, always an infection. Okay, let's have this clear. So let's come into a picturistic view. The vessels coming to the metaphysis, they are slow flowers, and the blood is undergoing an end stage to pass into a loop, which is shown in the slide. Or if you have trauma and thrombosis, bacteria would lodge in the area. They will have bacterial colonies, and they can, through damaged vessel walls, pass into the tissues and lead to the destruction of bone. The infection results in the formation of abscess at the region of the metaphysis. The pus so formed finds its way out through the area of least resistance. In children, less than 2 years, periosteum is loosely attached to the cortex and hence forms a potentially weak point. So what happens? You have a cavity of pus that you have bacteria in it. The pus is formed by killed or murdered polymorphonuclear leukocytes and leukocytes and macrophages. What happens? The macrophages come and ingest the bacteria. But the bacteria are wise. When they are within the macrophages, they destroy them and they remain alive. The pus is a collection of dead leukocytes. It's true, some of the bacteria might die, but not all. And they are surrounded by protections. They are an intelligent army. They might go through the cortex to the subperiosteal region. They go via the Volkmann canals, and the pus collects beneath the periosteum. If it is under tension, it will perforate the periosteum and go to the surface and lead to a sinus tract. Bone is hard. Bone is firm. When you have a collection of pus with pressure within, this presses on the nerve fibers. And these patients will have pain. They would have pain. And that's the reason why they have pain. The subperiosteal abscess, so developed, would either spread through the soft tissues or drain to the outside by forming a sinus, breaking the skin, or it will percolate down towards the diaphysis between the periosteum and the cortex and enter the shaft through the widened aversion pores due to anoxia. When the pus seeps underneath the periosteum, you have the nutrient vessels that supply the diaphysis. These may be blocked by thrombosis or by pressure, and as a result, you get necrosis of the whole diaphysis at times. The growth plate limits spread to the joint. And between the ages of 2 and 16 years, the periosteum is firmly attached to the cortex. And with the growth plate still present, the pus has to spread towards the diaphysis at a slow pace. And for this reason, I tell you, depending on the age, depending on the position of the periosteum, whether it is firmly attached to the cortex, you will get, as a result, مثلا إذا عندك a group of army people blocking one street and blocking another street, and only you have one street which is open. بصير عندك زحمة, بصير عندك pressure, and this forces the pus to go through one direction to the diaphysis at a slow pace. Above 16 years, the growth plate has disappeared. The periosteum is firmly adherent, and the pus spreads towards the diaphysis very slowly. This is showing you the various ages of how pus will seep down. either go to the subperiosteal region or go to the diaphyseal region. This still shows you the pus going to the subperiosteal region. Now, how does this human being react? The periosteum consists of two layers. The cambium layer is the active layer, and this reacts by forming new bone. And as a result, you have the involucrum. The involucrum means in Greek to wrap, to wrap. It surrounds, and you have vital bone formed. And in the center, you have dead bone. The dead bone, which is devascularized and dead and surrounded by pus, is known as the sequestrum. Dead bone, sequestrum. Viable bone, involucrum, formed by the periosteum. So you have the pus, you have the cortex, destroyed, partially destroyed, the involucrum, you have the bone abscess, and you have pus in the medullary cavity. Now, quick facts spread in the acute osteomyelitis. Less than 2 years, subperiosteal pus is common, the diaphysis is rare, and the joint space is rare. Why? And you have the physis present. We know that the physis is resistant to the spread of pus. Why? The reason why is that less than 18 months, there is circulation between the epiphyseal ossification center and the metaphysis. Pus can go through this, but if they're older, when there is no longer any circulation in the region of the physis, then it becomes resistant to spread of pus to the joint. At 2 to 16 years, subperiosteal is rare because I said that the periosteum is closely adherent to the cortex. So the diaphysis is common to have a spread, but it's slow. And greater than 16 years, the diaphysis is common, but the flow is very slow, and the joint space is involved. And you can have extra periosteal spread due to sinuses that have arrived from the pus, coming from the medullary cavity, through the Volkmann canal, to the subperiosteal region, through the periosteum, into the subcutaneous and muscular tissues to the outside. But this is also rare. The osteoblasts undergo necrosis, activation, necrosis, and as a result, we all know that the osteoblasts are the cells that stimulate that osteoclast through the rancle. And there is release of inflammatory mediators, there's recruitment of inflammatory cells, and the blood vessels. Believe me, when you ask a question, do children with osteomyelitis have thrombosis and embolus spread to other areas of the body? The answer is yes. Now, all these cause a purulent exudate. Together, a subperiosteal abscess forms when the exudate penetrates the porous metaphyseal cortex in bones with an intra-articular metaphysis. And this question we love to ask. We love to ask. And these, that there are 4 joints in the body where the metaphysis lies within the capsule. And you should know them: the shoulder, the hip, the ankle, and the elbow. Be careful. You should know these questions. And these are questions we ask in the board. Chronic osteomyelitis, you have preosteal elevation deprive the underlying cortex or cortical bone of its blood supply, as I told you, creating a necrotic piece of bone. The whole area, the whole bone can become necrotic. And this is called sequestrum or dead bone. The preosteum may form an outer layer of new bone, as I mentioned, the involucrum. What's the mechanism in which infection occurs? Local trauma has been associated with the development of acute hematogenous osteomyelitis because the bone becomes more susceptible to bacterial seeding. The combination of trauma and bacteremia seems requisite, and either one in isolation does not appear to cause acute hematogenous osteomyelitis. A bit about the bacteriology. In all age groups, most cases of acute hematogenous osteomyelitis are caused by Staph aureus. There has been a tremendous increase in infections caused by what we say community-acquired methicillin-resistant Staph aureus. From now on, I will call it CAMRSA. Some strains of CAMRSA harbor genes. They harbor genes. Pay attention. This is another question we like. They harbor genes encoding for Panton, Valentine, leukocidin, PVL. PVL is the briefing of this term, the gene. PVL positive change of CAMRSA are associated with complex infection. That's why we get methicillin-resistant Staph aureus with more multifocal infections in multiple areas. They have prolonged fever, they have myositis, pyomyositis, intraosseous, or subperiosteal abscesses, chronic osteomyelitis, and deep venous thrombosis. Keep this in mind, my fellows. Keep this in mind. We would hate it. There are certain communities that have the methicillin-resistant Staph aureus, and they are a killing disease for the surgeon. Now, we have certain bacteria, they attack individuals at certain ages. You have the neonates, they have group B, streptococcus, Staph aureus, or gram-negative bacilli. Infants and children younger than 4 years, they have Staph aureus, strep, group A strep, Haemophilus influenza, if not vaccinated. We used to have it very frequently in the past. Now that, thank God, we have the vaccine, it has nearly disappeared. Okay, so you have to pay attention to this. If the patient is allergic, then you have to choose another antibiotic for these. And the best antibiotic would be clindamycin and vancomycin. Children older than 4 years, Staph aureus, coagulase positive. This is very common. Septic shock requiring intensive care admission. The most common is the MRSA, and methicillin-sensitive Staph aureus. Post-operative and nosocomial infections, MRSA and coagulase-negative Staph aureus. A shoe puncture. Many times I get children with the puncture through the sneakers, and we see that there's a small penetrating hole in the plantar aspect of the foot, and we take a culture, and often we are lucky to demonstrate Pseudomonas infections or Staph aureus. And of course, we know that patients with sickle cell disease. In the past, we used to think that Salmonella was the most common organism. Nowadays, we know that Staph aureus is more common than Salmonella, but both exist. The evaluation of a patient with acute hematogenous osteomyelitis can vary from an intermittent limp and low-grade fever to septic shock. They are extremes. Some can come to you and have the infection and nearly have no pain. So you have to pay attention to this. You have to take a proper history. The history should cover fever, pain, limp, refusal to bear weight, and recent local trauma or infection. Immunization history must be obtained, particularly with regard to Haemophilus influenza vaccination. Use of antibiotics may mask symptoms. Examination of the child should be adequate and complete. The child should be examined. You should look at the general appearance. You can tell a child when he's sick, when he's suffering from pain. A child will not allow you to approach him or approach the area of pain. If you're dealing with a young child, you see that if it's in the hip will be flexed and externally rotated. Why? Because if there is pus, the maximum zone of pus collection will be in the hip. You should observe whether the child is able to bear weight or walk. Point tenderness is important, including the pelvis, the spine, and the lower extremities. Range of motion of all joints should be evaluated. If you see that there's an area of warmth, edema, and erythema, you should beware that there is something going on. And of course, the temperature and vital signs should be measured to rule out hemodynamic instability. What about the laboratory findings? The initial blood work should include C-reactive protein, erythrocyte sedimentation rate, blood cultures, and white blood cells counts with differential. The C-reactive protein is elevated. In 98%, it is the most stable one which elevates. Of 98% of patients with acute hematogenous osteomyelitis and becomes abnormal within 6 hours. So it is one which is nearly always elevated, always, 98% of cases, and it is elevated in a short while within 6 hours. The sedimentation rate, or ESR, becomes elevated in 90%. Pay attention. One 98%, the other 90% of patients with osteomyelitis, and peaks after 3 to 5 days, and it takes longer to subside after treatment. Blood cultures may yield an organism only in 30% of the time. The white blood cell count is elevated in only 25% of the patients. We always aim at trying to obtain a blood culture, and then we think of treating the patient. At times, we're not successful, and then we have to treat them blindly. What about the diagnostic imaging? Plain radiographs do not show bone changes. We do know it, and this is very common to be asked. Patients with osteomyelitis, if you take a plain X-ray, it won't be apparent by X-ray prior to 7 to 10 days or even 2 weeks. But it can demonstrate deep, soft tissue swelling and loss of tissue planes. Technetium-99 molybdenum bone scan can help to localize the focus and will demonstrate a multifocal infection. The overall accuracy is 92%. A cold bone scan is associated with more aggressive infections. Why? Because it has destroyed the circulation. It has destroyed all the inflammatory processes. And this is a warning sign that in these cases, you may require surgical treatment. MRI has a sensitivity of 88 to 100%. MRI detects marrow and soft tissue edema seen early in infection, as well as abscesses requiring surgical drainage. MRI assists with preoperative or postoperative planning when there is a poor clinical response to antibiotic therapy or after surgical drainage. CT demonstrates abscess formation. Jemīع, we hear that CT, the radiation nowadays, they're concentrating on it, and the amount of radiation produced by CT is decreasing in the newer machines. But it does help us in osteomyelitis. It demonstrates abscess formation and bony changes, but is most helpful later in the disease course. What is the differential diagnosis? The differential diagnosis for acute hematogenous osteomyelitis includes cellulitis, septic arthritis, toxic synovitis, fracture, thrombophlebitis, rheumatic fever, bone infarction, Gaucher's disease, and malignancy. The most common malignancy of children is leukemia, and they would have bone pain, and they have multiple bone pain. So keep this in mind. Treatment. Aspiration of the suspected area is the first step in management. On examination, why did you examine this patient well? You tried to localize the area. You tried to see the area of redness, inflammation. You tried to see where the patient is having maximum pain on tenderness, on pressing in the area. Aspiration is performed before commencing antibiotics. Yes, that's important because we want to demonstrate, if we can, the organism by culture. And if the clinical condition of the patient allows, you should send the culture for all studies. Every culture should be biopsied or studied histologically and culture-wise. You should do anaerobic and aerobic culture. You should do tuberculosis culture. You should use the Nelson agar or Nelson stain. Diagnostic aspiration helps guide the medical management when the organism is identified in 50% of the cases. Susceptibilities and resistant strains of CA-MRSA vary by community, adding to the importance of culture. A large bore needle is used to aspirate both the subperiosteal space and the intraosseous space. After aspiration, antibiotics may be started according to the guidelines in the table that I have presented prior. This very same table. You should follow the principle and give the antibiotics corresponding to the various organisms and their sensitivity to it. Non-surgical treatment. If no purulent material is aspirated, the child can be admitted for intravenous antibiotics. This is what I told you at the beginning. If you don't have any pus to culture, but the patient tells you, I have osteomyelitis, and you cannot demonstrate it, you should start the patient on intravenous antibiotics because of the frequency of CA-MRSA. It should be covered in most, if not all, cases. Surgery is not indicated if the patient demonstrates clinical improvement within 48 hours. The duration of intravenous antibiotics is usually 4 to 6 weeks. Surgical. What are the indications for surgical drainage? Number one is aspiration of pus. The abscess formation on imaging studies and failure to respond adequately to non-surgical treatment. These are 3 points I usually follow. And if I observe that I put the needle and I have penetrated the periosteum and the cortex, and I get pus, this is an indication. You should not say that, oh, I aspirated the pus, it's enough. No. Once you see pus, you have to do surgery. You have to evacuate the area completely. In addition, if you see on various studies, MRI or whatever study, ultrasound or whatever study, abscess formation on imaging studies, you should operate. And failure to respond adequately to non-surgical treatment is also an indication. A question that I'm asked frequently. If you have a patient with the hip and the child is holding the hip in flexion and external rotation and abduction due to the mass, how much fluid it can collect. You try to aspirate, you're not successful. You should operate on this patient. You should operate. Now, there is an argument saying, would you go front or behind? The ones who go from behind, they say that when you put the drain, the child is supine and the pus will seep out. The ones who go from the front say that it's better and they've had better results by going from the front. The contraindications are hemodynamic instability is a contraindication to emergent surgery, and the child should be stabilized first. The procedures, surgical drainage requires evacuation of all collections of pus, debridement of devitalized tissue, and drilling of the cortex to drain intraosseous collection. Don't be afraid to drill the cortex. You should create a source to empty the intramedullary cavity. If you have a sequestrum, you should operate and get it out. If it's quite large, it won't be resorbed. Samples should be sent for culture and histology to rule out neoplasm. The wound can be closed over drained if deemed adequately debrided, or packed and re-debrided after 2 to 3 days before closure over drains. With chronic osteomyelitis, a more aggressive debridement may be necessary, at times including excision of the sequestrum. Complications of acute hematogenous osteomyelitis includes meningitis, chronic osteomyelitis, septic arthritis, growth disturbance, pathologic fracture, limb length discrepancy, gait abnormalities, and deep vein thrombosis. Subacute osteomyelitis. I want to ask, am I clear? Am I clear so far?
واضح جدا دكتور.
واضح جدا. Okay. So I'll carry on. Subacute osteomyelitis. An overview. Subacute osteomyelitis is an uncommon infection characterized by bone pain and radiographic changes without systemic signs. Ya Jama'a, you don't realize how much subacute osteomyelitis can confuse the picture, especially in differentiating it from certain tumors, like an osteoma, like a ring sequestrum. So you have to know about it. Delayed diagnosis is common, and usually it affects the lower extremity, long bones, but it can occur in other sites. It most likely is due to an altered host pathogen relationship combined with increased host resistance. It is a statement that is said about it. They say it's due to increased immune defense of the host and poor virulent organisms causing it, like Staph viridans, which is not very aggressive. There is a decreased virulence of the causative organism and or antibiotic modification. In a retrospective study of subacute hematogenous osteomyelitis in children, Roberts et al. Found that antibiotics had been given to 40% of patients for infections other than osteomyelitis. So you have to pay attention. It is due to us in many ways by improper management of your patients. It most likely is due to pathogen relationship combined with increased host resistance, decreased virulence of the causative organism, and or antibiotic modification. In a retrospective study of subacute hematogenous osteomyelitis in children, Roberts et al. Found that antibiotics have been given to 40%, we mentioned this, in patients. Okay? ليه ما عم بتغير يا جماعة؟ Okay, now هلا عم بتغير. As a result, the children appeared less ill and displayed less toxicity than children with acute osteomyelitis, frequently presenting with a limp but without the features of typical osteomyelitis. Because children with subacute osteomyelitis appear less ill, they frequently present later in the course of their disease. Okay. A bit about the pathoanatomy. The genesis of subacute osteomyelitis is the same as acute osteomyelitis. The difference in presentation results from increased host resistance. Again, less virulent organism, prior antibiotic exposure, and or a combination of these factors. Meaning, to tell you it more in a simplified fashion, if you look at the pathoanatomy and the pathophysiology of this condition, it starts just like an acute osteomyelitis. But the organism is less virulent. The host has better health and has better defense mechanism. And there is a tendency nowadays to give antibiotics right and left. And this is a factor in causing subacute osteomyelitis. The Staph aureus causes most of the cases. The features of acute and subacute hematogenous osteomyelitis are compared in the next slide, which I will be showing you. Most cases of subacute hematogenous osteomyelitis are due to staph organisms, but recently streptococcus organisms have been found. Often, you cannot isolate any organ. This is a slide which I like very much, and it tells you about the difference in presentation between a subacute and acute osteomyelitis. We all know that in subacute, the pain is mild, fever is low, and occurs in few patients. Loss of function is minimal. Prior antibiotic therapy, often we get it in 30 to 40% of patients. White blood cell count is rarely elevated. The ESR is elevated in the majority. Blood cultures rarely give us positive findings. Bone cultures are 60% positive. Initial radiographs frequently abnormal, and they can occur in any location. On the other hand, you find that the acute are far more severe, they are far more aggressive, they have far more pain, they have far more limitation of motion of the joints, and of course, they have more white blood cells, and ESR is elevated, plus C-reactive protein, etc. Subacute hematogenous osteomyelitis may be confused with other neoplasms. And such neoplasms, we all know, are giving sarcoma and other tumors. Okay, you have to pay attention. Why? Why? Because they develop more of reactive tissue, more of sclerosis. Many times I have been asked to tell the difference between a subacute osteomyelitis and an osteodystroma. You have to keep this in mind. But pain is the most consistent symptom, and constitutional symptoms are usually mild. The ESR, however, is often elevated in these patients. Radiographic bone lesions, which may be difficult to differentiate from lesions due to other diseases, are commonly seen in the Gledhill-McIntyre described 4 radiographic types. He says there are type 1 is a solitary localized zone of radiolucency surrounded by a reactive zone, suggesting an eosinophilic granuloma or a Brody's abscess. You all know what a Brody's abscess is. It's a localized lytic lesion surrounded by sclerosis. And this is typically a subacute osteomyelitis. Type 2 is a metaphyseal lesion associated with loss of cortical bone. Type 3 is a diaphyseal lesion with excessive cortical reaction. And type 4 is a lesion associated with onion skin layering of subperiosteal bone. This classification has been modified to include other variants of infection. This is what I'm describing. First, it's a localized lesion surrounded by sclerosis. Then you have a superficial lesion. Then you have a lesion within the medullary cavity communicating with the outside. And finally, you have a massive lesion with periosteal bone formation and reactive bone formation, which is the involucre. In patients older than 18 months of age, acute hematogenous osteomyelitis rarely crosses the physis, as I have mentioned at the beginning. However, subacute osteomyelitis frequently does cross the physis. There is rarely a permanent damage to the growth plate in these patients. So you have to realize this point. And many times you ask the question why, which is not answerable. When the cortex is destroyed, as in Gledhill type 2, or when there is extensive cortical reaction in Gledhill type 4, neoplasms such as eosinophilic granuloma, Ewing sarcoma, osteogenic sarcoma should be considered in the differential diagnosis. As many as 50% of the cases, subacute osteomyelitis is confused with tumor. A biopsy is usually needed for definitive diagnosis. Antibiotics are given post-operatively and were used for 6 weeks in the series of Gledhill and McIntyre. The evaluation, the history. The history is notable for the absence of fever, malaise, or anorexia. The only symptoms may be an intermittent limp or pain. Physical examination includes point tenderness, as I've always stressed, over the involved bone is often the only clinical finding. What about the laboratory findings? Blood tests are usually not helpful in subacute osteomyelitis. The white blood count is usually normal or slightly elevated. The ESR is slightly elevated. The C-reactive protein is normal, and the blood cultures are negative. So when you have such a lesion, you have to be careful. You have to differentiate it from a benign tumor or even from other lesions where you have sclerosis, like an eosinophilic granuloma. Diagnostic imaging. Plain radiographs are positive for changes that range from a well-circumscribed radiolucency in the metaphysis or epiphysis to preosteal new bone formation, suggestive of an aggressive malignancy. Bone scan is usually positive, and this is positive in osteodystroma. So you have to be careful about this. CT and MRI help characterize the lesion, but MRI provides more information. Classification. The classification is based on the appearance of the lesion on plain radiographs. In all cases, the plain radiograph differential diagnosis includes neoplasm. And I got this from a textbook, which is very nice. And they classify them into 6 types. Type 1A is characterized by a punched out radiolucency suggestive of an eosinophilic granuloma. I'm sure many of you busy people have seen it. Type 1B is similar, but has a sclerotic margin and represents a classic Brody's abscess. Type 2 is a metaphyseal lesion associated with loss of cortical bone. Type 3 is a diaphyseal lesion with excessive cortical reaction. Type 4 is a lesion associated with onion skin appearance, and here Ewing sarcoma comes into the picture. Type 5 is a concentric epiphyseal radiolucency, and you have to distinguish this from chondroblastoma. And finally, type 6 is an osteomyelitic lesion of the vertebral body with complete destruction of the vertebral body. What about Brody's abscess? I spoke to you a lot about it, but what about it? Since Brody's description of the lesion, a localized metaphyseal tibial abscess without any associated systemic illness, and Brody described it in 1832, and these lesions were named after him. Brody's abscess may be thought of as a form of subacute pyogenic osteomyelitis. Most Brody's abscesses occur in the metaphysis, Glidhill type 1 lesions, and usually respond well to surgical debridement and postoperative antibiotics. What about primary epiphyseal osteomyelitis? Here, this is a problem because we confuse this with chondroblastomas. Epiphyseal osteomyelitis may be either acute or subacute. Primary subacute epiphyseal osteomyelitis was described by King and Mayo in 1969 and can be thought of as a Brody's abscess of the epiphysis. Subacute osteomyelitis appears to act the same whether it occurs in the epiphysis or metaphysis. While most cases of epiphyseal osteomyelitis are subacute, acute cases have been reported. A biopsy is usually needed for diagnostic purposes and for differentiation of the lesions from neoplastic lesions, including osteoid osteoma. Most often, no causative organism is found, but when one is isolated, it usually is Staph aureus. I know I told you about Staph or Strep viridans, but Staph aureus is more common. At surgery, granulation tissue is usually found instead of pus. Surgical treatment or debridement, followed by intravenous and oral administration of antibiotics, is indicated. Some lesions will heal with antibiotics alone. Treatment. Non-surgical lesions without malignant features may respond to antibiotic therapy covering Staph aureus. Surgery is most commonly needed in cases of subacute osteomyelitis. Surgical indication. Surgical treatment is indicated in all patients with aggressive features that would let you worry about it. Could this be a tumor? On radiographs, types 2, 3, and 4. A biopsy is required to rule out a malignancy if such radiographic features are present. A biopsy and culture is performed using an approach that does not contaminate more than one muscle compartment. This is very important in case a malignancy rather than the infection is present. Once osteomyelitis is confirmed, the lesion can be treated with curettage and antibiotics. Complications, gross disturbance is unusual. Chronic osteomyelitis can result. Septic arthritis. Are there any questions? Are there any questions?
Sir John? Okay, you can proceed. Okay.
Okay.
If you want to ask, okay, but
Okay.
because of the time, okay.
I want to ask. Let us ask. I saw that there is Hamza Ismail Al-Qaddas. Is she present? Is it a male or female? مين حمزة؟ eh?
Hamza بس.
True.
Okay, ask Hamza, Dr. Hamza with you.
Okay. I want to ask, how would you explain the occurrence of septic arthritis in a patient with an acute osteomyelitis in the metaphysis of the neck of the femur? How would you explain it? I want you to ask me questions. I want you to ask me so as to help you. I am the patient. I'm having pain in the hip, and you want to rule out septic arthritis. How would you do it? شو يا حمزة؟ سمعني صوتك علي لأن أنا ما بسمع.
I cannot understand the question. Sorry,
The
sir.
question, عندك patient with localization of an infection in the neck of the femur.
Yes.
You want to rule out a septic arthritis. What are the routes in which the infection could reach the joint? And what study would you ask for? Very quickly.
Ultrasound and aspiration for inflammatory marker ASR CRB. The also osteomyelitis in the proximal femur might reach to the joint because the metastasis of proximal femur intracapsular.
Very good. So, if the patient is younger than 18 months, how would the infection reach the hip joint?
By vascular
ما اسمعك.
facial capillaries. Because
ما عم بسمع خالد.
Because in pediatric, in less than 8 months, there is facial capillaries between the epiphysis and the metastasis. So
برافو عليك. Very good. وشغلة تاني بالهيب، شو في بالهيب لحتى ممكن بلا ما use the arteries that they can reach the joint.
Sorry, sir.
Where is the metastasis in the hip of the neck? Huh? Intracapsular. برافو حمزة. هيك بدي اياكم توقفوا على اجريكم وجاوبوا انتوا لازم تكونوا اكيدين من حالكم، وصدقني على الوقت بتكون احلى الشباب موجودين بالاربورد. Thank you حمزة. Very good answer. Septic arthritis. Septic arthritis is a surgical emergency. Delayed treatment can cause permanent joint damage, deformity. We know why. Why? Because there's a process of lysis going on. The cartilage is destroyed. You have to pay attention to this. And they end up with long-term disability. This happens in people where they are present in low socioeconomic countries, and they disregard the seriousness of having pain. And with time, they have destruction of the joint cartilage, and they have deformities, they have shortening, they have everything you want to ask about. So, poor outcomes follow delayed diagnosis. The incidence of septic arthritis peaks in the first few years of life. 50% of cases of septic arthritis occur in children younger than 2 years. Why? Because Hamza answered very well. The organism can seep from the metastasis through the physis into the epiphyseal ossification center. Because we know that the vessels are still patent until 18 months. Large joints like the hip and knee are most commonly involved. A bit about the pathophysiology. Most cases of septic arthritis result from bacteremia seeding the joint. Direct inoculation of the joint from trauma or surgery. Contiguous spread from adjacent osteomyelitis. What happens when the pus goes into the joint? There's a release. of proteolytic enzymes from the inflammatory cells, from the synovial cells, cartilage, and bacteria, and these cause damage to the articular cartilage within 8 hours. Imagine how acute this is. This is considered a very serious emergency. Increased joint pressure in the hip may cause osteonecrosis of the femoral head if not promptly relieved. Staph aureus, as usual, causes more than 50% of the cases. The incidence of Haemophilus influenza, septic arthritis, has decreased markedly since the advent of Haemophilus influenza vaccine. So we go and come back to the same table and with what to give. This table, you should put it by your bedside and memorize it. You should go into the history. The history of septic arthritis is similar to osteomyelitis. A history of rash or swollen lymph nodes is important for their association with other conditions in the differential diagnosis. The vaccination history must be obtained. Patients have fever and often appear toxic. There is disuse of the extremity and or refusal to bear weight. Septic joints have an associated effusion, tenderness, warmth, and any motion causes severe pain. The extremity rests in a position that maximizes the volume of the joint. For the hip, the result in hip flexion, abduction, and external rotation. And this is known as the Faber position. Why? Because the joint is at maximum diameter at that position. The white blood count is elevated in 30% to 60% of patients, and 60% of those will have a left shift. The ESR is often elevated, but may be normal early in the course. An elevated C-reactive protein is the most helpful blood cultures and should be drawn because these are often positive, even when local cultures are negative. What about the imaging? Plain radiographs may show joint space widening. You have to look at the joint space widening, and are needed to identify any possible bone involvement. Ultrasound, as our friend mentioned, Hamza, will tell you a lot also. Will tell us about the presence of a hip effusion and can be used to guide joint aspiration. Ultrasound cannot differentiate, of course, between septic and sterile effusions, which occurs, for instance, in transient synovitis. MRI detects a joint effusion and can assist or assess for adjacent osseous involvement, but it can be difficult to obtain expeditiously. Aspiration. Joint aspiration is necessary for the diagnosis. Fluid samples should be analyzed for cell count with differential, as shown in table 2, which I will not be showing. Gram stain and culture. I have it. So you have these studies. What are they? You have to look at them studying it, look at the difference between a septic arthritis and other conditions. For instance, you have traumatic effusion, you have toxic synovitis, you have acute rheumatic fever, juvenile rheumatoid arthritis, and look at septic arthritis. It is the highest amount of leukocytes and the highest amount of polymorphonuclear leukocytes. The differential diagnosis includes osteomyelitis, toxic synovitis, viral arthritis, inflammatory bowel disease associated with arthritis, post-gastroenteritis. Don't forget about tuberculosis, which is becoming more popular and becoming popular in low socioeconomic areas. Lyme's disease is very popular in the States. Post-streptococcal arthritis, juvenile arthritis, Reiter's syndrome, reactive arthritis, villonodular synovitis, leukemia, sickle cell disease, hemophilia, serum sickness, and Horner-Schonlein purpura. يا جماعة, these conditions you should know each of what is. And these you should include in the differential diagnosis. Children with septic arthritis appear thicker and are more in distress than those with typical synovitis, okay, or transient synovitis. Children with synovitis appear comfortable and may be playful when the hip remains still. Juvenile rheumatoid arthritis rarely presents in the hip. For the hip, slipped capital femoral epiphysis, leg calviparosis disease, fracture, and the psoas abscess belong to the differential diagnosis. The accurate diagnosis requires synthesis of clinical findings, laboratory studies, imaging, and judgment. If all four of the following are present, probability of septic arthritis ranges from 59 to 99.6% in various series. Fever is greater than 38.5. Transient synovitis is less than 38. Inability to bear weight. ESR greater than 40. White blood cell count greater than 12,000. A C-reactive protein greater than 2 is an independent risk factor for septic arthritis. The order of importance of predictors is fever greater than 38.5 degrees, elevated C-reactive reactive protein, elevated ESR, refusal to bear weight, and an elevated white blood cell count. ما بتغير هاي ليه؟ هلا Okay, treatment. Treatment starts with joint aspiration, preferably before starting antibiotics empirically. Intravenous antibiotics are started after samples are sent for culture and are usually administered for 3 weeks. The child's immunization status should be checked to determine whether Haemophilus influenza needs to be covered by the empiric antibiotics. Non-surgical, there is rarely a role for non-surgical treatment. Rarely, pay attention, although some surgeons advocate intravenous antibiotics and serial aspirations for accessible joints. ليه ما بتغير؟ The indications for surgical drainage is the standard care for almost all septic joints to clear the joint of damaging enzymes, to clear the joint of proteolytic enzymes. With possible septic arthritis of the hip, it is better to err on the side of drainage. The morbidity from surgical drainage is much less than that from neglected septic hips. Contraindications: surgical treatment is contraindicated when the patient's clinical status prevents surgical treatment. An arthrotomy is performed to remove all purulent fluid and irrigate the joint. For the hip, an anterolateral or medial approach is performed emergently to decrease the risk of developing osteonecrosis. Joints like the shoulder, as I mentioned, elbow, knee, and ankle can be drained open or with an arthroscope. Rehabilitation: patients may start range of motion exercises in the first few days after surgery. Complications of septic arthritis are joint contractions, hip dislocation. Believe me, I've seen several hip dislocations, especially among the Puerto Rican children in the United States. I've seen gross disturbances, limb length discrepancy, joint destruction, gait disturbances, and osteonecrosis. The risk of meningitis is highest with Haemophilus influenza infections, but thank God now we have the vaccine. Special infection. Neonates. Neonates younger than 8 weeks of age deserve special consideration because of their immune systems are immature. Neonates are more susceptible to infection and often do not manifest the symptoms and signs that normally assist in diagnosis. Their immune mechanism is not developed. Neonatal intensive care units. Infants, neonatal intensive care unit infants are at risk for infection because of phlebotomy sites, indwelling catheters, invasive monitoring, peripheral alimentation, and intravenous drug administration. Multiple sites of infection are present in 40% of neonatal intensive care unit infants with musculoskeletal infection, typically due to Staph aureus or gram-negative organisms. So you have to pay attention. The intensive care unit is not innocent. So you have to take the necessary precautions. Otherwise, healthy infants who develop an infection between 2 and 4 weeks of age at home, usually it can be group B streptococcus is usually the causative organism. Usually only one site is involved. And patients with Kingella, septic joints have fewer systemic signs and less joint irritability than do those with septic joints due to other organisms. I would like to mention at this point, nowadays, statistics is showing that Kingella is becoming more common as a cause of infection than Staph aureus. And these patients are not so sick as those with Staph aureus. And many times you can miss the diagnosis. ما متغير. Anatomy. Before the secondary center of ossification appears, the metaphyseal vessels also supply the epiphysis. So osteomyelitis in the metaphysis, 76% of cases spreads to the epiphysis and the adjacent joints. هيدي اللي عم نحكيها. إنه in infants, there's a continuous connection. And this is how the infection spreads in these neonates. And as a result, you can have significant gross disturbance and physical arrest. The diagnosis in the neonate can be difficult. Fever is usually absent. Early signs are pain with motion. Decreased extremity use, pseudoparalysis, difficulty feeding, and temperature instability. Tenderness, swelling, and erythema occur later. The white blood cell count is usually normal. Blood cultures are positive in 40%, and the ESR may be elevated. For Kingella, Kinge, the yield of positive cultures is higher if the sample is sent in a blood culture bottle. These should be used if there is a sufficient amount of specimen. Neonates with documented sepsis should have aspiration and culture of all suspicious areas. Positive areas should be surgically drained with care taken to avoid additional damage to growth centers. What about the shoe puncture condition? And this is quite a common cause. It can cause a simple laceration, cellulitis, septic arthritis, or osteomyelitis. And when an object has penetrated a sneaker, Pseudomonas is an organism of concern. And this is a question we usually like to ask. Although infection by Staph aureus is more common. Tetanus status should be ascertained and coverage provided if deficient. Radiographs should be taken to look for a retained foreign body. Initial treatment of soaks whenever you have a perforation of the sneakers, elevation, rest, and antibiotic therapy that covers both Staph aureus and Pseudomonas should be given. A poor response to this regimen indicates a more extensive problem. Bone scan or MRI can help diagnose more complex infections requiring surgical debridement. 15% of children following shoe puncture, wounds, and deep infection in approximately 1% occurs. Surgery is indicated for a foreign body abscess, septic arthritis, or failure to respond to antibiotics. Late deep infections are due to Pseudomonas in greater than 90% of cases. What about discitis? Discitis usually occurs in children younger than 5 years. These children refuse to walk. They have fever and they sit in bed. If you try to get them up, they won't walk. Infection starts in the vertebral end plate and moves to the disc through vascular channels. Staph aureus causes most cases. Blood cultures should be obtained, but local cultures are not routinely needed. Patients present with low-grade fever, limp, or refusal to bear weight. The child refuses to move fine. Plain radiographs are normal for the first 2 to 3 weeks, but they may show loss of normal sagittal contour early. Bone scan or MRI confirms the diagnosis earlier. Antibiotics successfully treated. Most cases, patients who do not respond to antibiotics should have a biopsy. Plain radiographs are normal for the first 2 weeks, but they may show loss of normal sagittal contour. Early bone scan or MRI confirms the diagnosis. Antibiotics successfully treat most cases. Patients who do not respond to antibiotics should have a biopsy. So vertebral osteomyelitis affects older children. More constitutional symptoms are usually present with vertebral osteomyelitis than with discitis, and there is more focal tenderness on examination. MRI on bone scan is sensitive early. Plain radiographs show bone destruction. Later treatment with anti-staph phylococcal agent is curative. Briefly about sickle cell disease. Children with sickle cell disease are at increased risk for both septic arthritis and osteomyelitis. The frequent bone infarcts, sluggish circulation, and decreased opsonization of bacteria all contribute to the susceptibility. Staph aureus and salmonella are the most common organisms, so initial antibiotic treatment should cover both. Only approximately 2% of children with sickle cell disease admitted to a hospital with musculoskeletal pain have osteoarticular infection. A positive blood culture or positive osteoarticular aspirate is diagnostic. Now, we're going to go through what should we know about tuberculosis. The incidence of tuberculosis has been rising in developed countries over the past 30 years because of immunocompromised patients and emergence of multi-drug resistant strains. Also, patients who are taking things like intravenous tranquilizers or etc. are predisposed to it. Children are more likely to have extrapulmonary involvement with bone and joint involvement, occurring in 2% to 5% of children with tuberculosis. The most common sites of musculoskeletal involvement in tuberculosis is the spine, 50%, large joints, 25%, and long bones, 11%. Polyostotic involvement or miliary tuberculosis has been reported in 12%. Children are more likely to have Patients can present with fever, night sweats, weight loss and pain. Patients with skeletal infections however, may have more subtle findings. Many of these patients live in a poor socioeconomic area. There are many crowding in rooms, and they can have mild pain with normal blood studies. In the spine, the anterior 1/3 of the vertebral body is usually involved, and most often in the region of the thoracolumbar spine. It's the area where we get the gibbets. A paravertebral abscess may cause neurologic deficits. Long bone lesions are radiolucent with poorly defined margins and surrounding osteopenia. The hip and knee are joints most commonly affected. Involved joints have diffuse osteopenia and subchondral erosions. The white blood cell count in tuberculosis is normal. The ESR is usually elevated, and the purified protein derivative test, the PPD, is usually positive. A biopsy with stains and culture for acid fast bacilla is diagnostic. Treatment is usually medical for at least 1 year. Surgical debridement of long bone lesions may hasten resolution or constitutional symptoms, but incisions should be closed to avoid chronic sinus formation. Drainage and stabilization of the spine lesion is indicated for neurologic deficit, instability, progressive kyphosis, and failure of medical therapy. So in brief, speaking about tuberculosis, we know that it's quite common to affect the lower thoracic region. We know that the thoracolumbar region, the vertebral body is destroyed. Why? Because it involves the vertebral body towards the end plate, and it spreads from one vertebra to the other via the anterior longitudinal ligament, just like one of these tumors that spread along the anterior longitudinal ligament, and they have signet cells. I really forgot the name, but they spread along the anterior longitudinal ligament upward or to other areas. Drainage and stabilization of spine lesions is indicated for neurologic deficits, instability, progressive kyphosis, or failure of medical therapy. Another disease which is known in the States, it's Lyme disease, and it is caused by Borrelia burgdorferi, and this causes erythema margins, intermittent reactive arthritis, neuritis. If you look at the leg, you see that it's red, and they have an acute arthritis. These are quite common, and it occurs from a tick and a bite from the deer tick, which is prevalent in New England and Upper Midwest. It is generally less painful than bacterial arthritis, and patients can present with fever and swollen, irritable joint, but will still bear weight. Erythema migrans is the rash typically seen after infection with Borrelia burgdorferi, although it is not always present. Classically, it is expanding. It's just like a bull's eye rash. The white blood cell count can be normal or elevated, but the ESR and C-reactive protein are elevated. Joint aspirates have markedly elevated white blood cell count. Serologic testing is positive for burgdorferi. The rapid Lyme immunoassay should include the septic joint evaluation and endemic areas. So the best treatment for this is to give doxycycline, amoxicillin, and spiroxy. Gonococcal arthritis is caused by Neisseria gonorrhea. It affects sexually active adolescents, sexually abused children, and neonates and infected mothers. And because the association of sexual abuse children with a suspected infection should have cultures taken of all mucous membranes. The knee is the most commonly involved, and this is quite common to occur in children, adolescents in the United States. We used to see many of them, and it would turn out to be gonococcus, and it's sexually related. So the treatment, ايه
السلايدات ما عم تقلب يعني
ما عم بتبين.
اي يعني على نفس السلايد يعني صارنا كثير.
هلا شايف
يعني the 8 long bone lesions are radiolucent. بس هذا السلايد وعلق عليه يعني.
شو برجع بفوت لان هلا وصلت للاخر تبع الفيرست سيشن. I want to just mention that gonorrhea is quite common, and if you do have it, you have to remove the pus and give, of course, we know penicillin. Okay.
ما عم تبين، هي وقفت على
ما عم بتبين. رح برجع بفوت أنا، رح برجع بفوت.
يلا.
بهالوقت خليهم يحضروا لي أسئلة. It's a very long lecture, huh? هلا بينت؟ خالد
ايوه
بينه؟
باينه ايوه الان بالسلايد اللي هو 112 رقم 112.
Is it clear now?
Now clear, yes.
Okay. Let us, we spoke about gonorrhea. Gonorrhea is very common in the adolescents in the US and in mothers who have gonorrhea and they deliver with the child, and the child can get gonorrhea from the mother. You have to pay attention to this. Now let's come and speak about a bit about fungus infections. Coccidioides immitis is a fungus endemic to southwestern United States that can cause polyostotic osteomyelitis in affected individuals. The infection starts as an upper respiratory infection, but can progress to disseminated disease in a small percentage of patients. The diagnosis is usually delayed. White blood cell count and ESR are often normal, and in addition to antifungal medical therapy, surgical treatment is usually required to eradicate the infection. Now, chronic recurrent multifocal osteomyelitis. This is the diagnosis of chronic recurrent multifocal osteomyelitis is an idiopathic inflammatory disease of the skeleton, and there is a diagnosis of exclusion. Chronic recurrent multifocal osteomyelitis is characterized by prolonged course of periodic exacerbations when there is associated synovitis, acne, pustulosis, hyperostosis, and osteitis. All put together, it's known as the Sappho syndrome. The condition is characterized by periods of exacerbation, but usually goes into remission after 3 to 5 years. The incidence is unknown. It occurs primarily in children and adolescents and is more common in girls. The peak age of onset is 10 years. The metaphysis of long bones and the clavicle are the most common involved. Clavicle involvement is common in CRMO, unlike in true infections. The pathoanatomy, the pathophysiology is unknown. Theories include an infection by an organism with fastidious growth requirements or an autoimmune disorder. The evaluation, patients have an insidious onset of episodic fever, malaise, local pain, tenderness, and swelling. On physical examination, patients have swelling and tenderness over the involved bone. They may have low-grade fever. Laboratory findings, the white blood cell count is usually normal. The ESR and C-reactive protein may be elevated. Bone cultures are negative. Plain radiographs show eccentric metaphyseal lesions with sclerosis, osteolysis, and new bone formation that frequently is symmetric. Bone scan helps identify all the sites of involvement because of shared characteristics between the CRMO and malignancy. MRI is helpful to judge the extent of soft tissue involvement of the lesion. Treatment, non-surgical, although many children have biopsies and local cultures at the time of initial presentation to establish the diagnosis. Treatment is always non-surgical once the diagnosis is established. Schedule non-steroidal anti-inflammatory medications during exacerbations, successfully manage the symptoms in 90% of patients. Surgery is indicated only when a biopsy is needed to establish the diagnosis. Now, these are the final points I would like to make in the first part of the discussion. We have covered everything in infection, and these are the final points you have to know. And the second part of these lectures are X-rays and how to diagnose. I will go very quickly through the second part. But now points to be noted, and I call this the most important part of the lecture. A child with bone pain and fever should be assumed to have osteomyelitis until proven otherwise. Acute hematogenous osteomyelitis without abscess can generally be treated medically. In areas with high prevalence of community-acquired methicillin-resistant Staph aureus, surgical drainage may be necessary even in the absence of documented abscess on imaging studies. If the response to antibiotics is poor, preoperative MRI aids surgical planning by delineating the extent of the infection and location of the abscess. Because of the prevalence of community-assisted methicillin-resistant Staph aureus, impaired coverage should cover community-assisted methicillin resistant Staph aureus. In most, if not all cases. Susceptibility and resistant strains of community-assisted MRSA vary by community, adding importance to aspiration or biopsy for culture. The metaphyseal blood supply crosses the physis to the epiphysis in children younger than 12 to 18 months, so severe sequelae are more common. In neonates, the most common organism is group B streptococci. This is a question we like to ask. If there is sufficient fluid from arthrocentesis, a portion of the sample should be placed in blood culture bottle because Kingella kingae grows more rapidly in this medium. Children with septic arthritis appear sicker and are in more distress than those with toxic synovitis. Children with synovitis appear comfortable and may be playful if the hip remains still. Check the child's immunization status to see if Haemophilus influenza coverage is necessary during empirics therapy. Juvenile rheumatoid arthritis rarely presents in the hip. In the intensive care unit, neonate babies with musculoskeletal infection, 40% have multiple site involvement. Infections in infants frequently cross the physis with resultant infection of the metaphysis and adjacent joint. Following nail puncture through a shoe, soft tissue infection occurs in 10 to 15% of cases, and deep infection 1%. Pseudomonas accounts for more than 90% of late deep infections following nail puncture through sneakers. Staph aureus and Salmonella are the most common infecting organisms in children with sickle cell anemia with musculoskeletal infection. In children with tuberculosis, the most common sites of musculoskeletal infection are the spine in 50% of cases, large joints 25%, and long bones 11%. Polyostotic involvement occurs in 12%. Lyme disease is often heralded by a typical skin lesion, erythema migrans. Chronic recurrent multifocal osteomyelitis is a diagnosis of exclusion. Cultures are negative. And unlike true infections, involvement of the clavicle is common. Now, this is the first part of the lectures. The second part will consist of radiology. And I would like to have a break of 5 minutes because I don't have my voice. I would like to rest. سمعت خالد؟ خالد
دكتور جون اوكي تيك يور ريست.
بدي ارتاح 5 دقائق لما عاد يطلع صوتي.
ايوه ملاحظين، واشرب لك حاجه دافيه.
راح بشرب مي هلا لعب له يجيبوا لي مي.
عماد بيسال يعني بيقول يعني how to differentiate vertebral osteomyelitis versus discitis، يعني كيف بتفرق بينهم؟
Well, actually, clinically, patients with discitis are at a younger age, or they occur secondary to disc surgery. Why? Because the blood supply to the disc is not present. And it obtains its blood nutrition by means of osmosis or absorption from the circulation, but not through the blood supply. In a spondylitis or spondylitic infection, the vertebral body is involved, and the disc is resistant to infection. Pus cannot pass through the disc. It goes along the anterior longitudinal ligament from one vertebral body to the other. Now, if you compare this to tumors, the disc is resistant again to spread. Why? Because the disc is resistant. There's no circulation. Okay? But when you have destruction of the vertebral body, the disc collapses together with the vertebral body. But clinically, discitis is a process very similar to spondylitis. They all present with paravertebral spasm, they have fever, etc. But usually it's more pronounced with the vertebral body. Am I clear so far?
Okay, دكتور شكرا.
خليني أقول شغلة. We know that the disc in spinal tumors is resistant to spread of the tumor. In cases where you don't have a tumor and you have infection is more likely to destroy the disc. Clinically, discitis will be present in a child more frequently than a vertebral body involvement. I've seen cases of discitis in children of 4 years, 5 years, and I've seen spondylitis. But in both, I think the symptoms are nearly the same. Now, as far as lab studies are concerned, I will consider that the vertebral body will give us more positive findings. I'm kind of wondering, what does he think? What does the one who asked that question think? حكينا مين اللي سأل السؤال؟
دكتور عماد يا دكتور.
عماد قل لي شو أنت what are you aiming for? I think both are an infection of the spine. Both give the same signs and symptoms. In one, you don't see so many findings like an elevated sedimentation rate or C-reactive protein, which is the discitis. In the vertebral body infections, you do see it more frequently. But that's what I am acquainted with. What do you have to add? Ask me. Let me know.
يعني هل ممكن نعتمد على الMRI
بتسأل عن الMRI. I mistook it. I talk clinically. Well, in an MRI, well, you see that there's increased signal intensity. around the disc in MRIs. At T2, it gives you an increased activity. You can tell this by MRI on T2, signal intensity. I think this is the most important point in discitis. Okay, so this is something we depend on. I think you see more inflammation in the thoracic and the vertebral bodies, but not in the disc. But you did in both, you see an increased signal intensity on T2.
Thank you.
That's it. I don't think there's anything more significant than this. I think CT scan would give us more information. A CT scan would give us more information about the vertebral body and the destruction of the vertebral body. But in both, when you have an infection and you have fluid, you have an increased T2 signal intensity. Okay, let's go on to the question. We spoke about transient synovitis. I want, who is the one who asked that question? He seems very brilliant. This question is directed to you.
Yeah.
You have a patient who's a child, 6 years old. He comes presenting to you with pain in the hip. Okay? What do you have to add on this patient? He has low-grade fever. يلا شو اسمه؟
نسأل لحظة الدكتور عبد الله تعال.
يلي سأل السؤال بدنا السؤال.
نفس السؤال عماد يلا معك.
عماد. يا عماد. شو يا عماد؟
سؤال مرة ثانية دكتور.
The question is, we have this X-ray. The X-ray is of a 6-year-old boy. He has a temperature of 37.8 centigrade. The ESR is 40. The C-reactive protein is normal nearly. You have this plain X-ray. They come to you and they show you this X-ray. What you have on this X-ray that will localize the area of the infection?
Ask about the fever is low or high grade to differentiate between arthritis and
ما عم بسمع يا جماعة. ما عم بسمع. خالد. Do you see in the joint any difference in the width? I'm going to discuss this. These patients with transient synovitis, they have a reactive synovitis of the hip. They have an increase in the width of the joint over here. They have fluid in the joint. And if you look over here, you begin to see that the muscle tissue, there is a cellulitis and there's inflammation. And this patient has a low-grade fever and he's suffering, but not severe, then you should think it's a transient synovitis. I'm going to go. Who loves to discuss this? This is a patient who has toxic synovitis. You can see that with ultrasound, you can demonstrate the amount of fluid in the joint. Okay, and this would tell you a lot about the patient having synovial sickness, and this is indicative of synovitis of the left hip. This is the same patient. I want to show you other things. This is a patient who has septic arthritis with fluid in the hip, and this patient had an osteomyelitis that had perforated into the capsule, and he has a combined septic arthritis and osteomyelitis. This is a patient who has had an MRI. You can see that is an increased signal intensity. I want to see if there's anything about the spine that the question was asked. This is a patient who has a plain X-ray, and you see that there is something over here with sclerosis. It's localized, it looks innocent, it's lytic, surrounded by sclerosis, and you have to think of probably a Brody's abscess or osteoma. This is an MRI on the same patient. These are the passage of, let me see. This one I would like to stress over here, that the most common organism that infects the bones is Staph aureus, followed by the respiratory pathogens, Kingeli, Kengi, strep, pyogens, and strep pneumonia. And this is becoming more and more popular. And then you have to know that patients who have the methicillin-resistant staph aureus, they have a pentalone, valentine, leukocidin, or PVL gene. And this helps in the protection of the mycobacteria, and it helps in necrosis of the surrounding tissue. It gives a toxin that produces tissue necrosis and destruction of neutrophils. Kingeli is difficult to identify, and many times you have to do a polymerase chain reaction test on it to identify it, if you detect it. Yeah, these are all. I just want to see if there's something on the spine that I have over here. And this is a very good question. These are spinal osteomyelitis. I want to see if I have anything on the spine. No, I have nothing on the spine. But let me see what we have over here. Spinal osteomyelitis has a bimodal incidence. There is one peak in the early childhood and another one in the sixth decade. The incidence appears to be increasing, and this is believed to be related to increased utilization of intravascular devices and intravenous drug abuse. The disease begins in the vicinity of the vertebral end plate, where there is metaphyseal equivalence. Bacterial infections involving the spine almost always affect the disc space. The most severe cases can extend into the epidural space and result in rapid neurologic deterioration, permanent sequelae if not treated immediately. Although most, 86% of epidural abscesses occur in association with osteomyelitis, epidural abscesses may be the only abnormality. Paraspinal abscesses formation may also occur with or without treatment to the central nervous system. Infections can be low-grade and produce only chronic back pain and destruction. These infections typically are caused by Staph aureus. There is an increased evidence of Kengele Kengi, and this may be responsible for spondylodiscitis. Radiographs obtained in part to exclude other pathologic conditions may show this space narrowing, effacing or sclerosis, end plates, and aligned abnormalities. Multiple levels are involved in 6% of the cases, and skipped lesions are seen in 3%. Contrast enhanced MR imaging should be obtained in all patients suspected of having spinal infection. In osteomyelitis, there's an abnormality in signal intensity of the disc and the adjacent end plates with paraspinal edema, signal intensity, or frank abscess. If there are neurologic findings, it is paramount to search for evidence of spinal epidural abscess. Spinal epidural abscesses is slightly more than 1/3 of the cases of spondylodiscitis and is seen as a ring-enhancing lesion within the epidural space with or without cord compression. Because of the frequency of non-contiguous skip lesions, it is advisable to image the entire spine. Surgery is indicated, and there are neurologic deficits. Let me see, that's it. I don't think, I'm going to look it up, Khalid. I don't think there's, by MRI, both would show an increased signal intensity on T2. I think the increased intensity is usually around the disc space, mainly. But should you have any collection within the disc, it would show an increased uptake. And that's it, increased signal intensity. Anyway, I would like to terminate this lecture here and tell you thank you. Khalid, شو عندك أخبار؟ شو بدك؟ بعد. Are there any questions more؟ ما تسألوني كثير عن السباين بهال MRI.
في سؤال واحد من الشباب.
لا ليك خالد شغلني لأن I would like really to know the question.
Okay.
I don't think there is a significant difference by MRI.
Okay, there is one question by Dr. Abdullah. He asked about the contraindication in taking aspiration or needle aspiration in joint septic arthritis.
During what?
During taking aspiration.
What are the complications؟ ما بسمع ما عندك الصوت انجي عم بسمع. Contraindications to aspiration when?
When there is joint fullness, effusion, septic arthritis.
What are the contraindications to aspiration? Well, I'll tell you something. One of the contraindications is we don't like to aspirate a joint if we don't have a culture. This is very important. But nowadays, and before making a proper diagnosis, if we don't find any pus, and then we want to do a scintigraphy or do an MRI, it will interfere with it. But you have to do it early to avoid this. Aspiration of a joint in septic arthritis is, in general, a must. There are rarely any contraindications in aspiration of a joint. We like to aspirate them. We like to evacuate. we like to remove the proteolytic enzymes. I don't think that there's any contraindication to aspiration in these patients, but there is a problem. There is a certain condition that you will end up re-aspirating and re-aspirating and re-aspirating, and we don't like this. And in general, we do prefer to evacuate the pus by open surgery. We don't like to aspirate. There are certain surgeons who make use of arthroscopy and evacuate the pus. They evacuate it. They remove it, and by means of endoscopy or arthroscopy. But I'll tell you something. These patients, many of them do recur, and you have to do it on on a repeated basis, and you can contaminate the joint further. Did I answer you? ما في جواب. خالد. Hello.
Hello, Dr. John. Nice answer. That we face always from our practice. Open drainage is better than recurrent aspiration.
Definitely.
Definitely, yes. I ask you, Dr. John, with you, Dr. Abdelnoor. What to ask you about today is there is a lot of talk about Klebsiella bacteria. But in our practice, we have if any culture repeat there is a growth of Klebsiella. Do you face like this?
And Klebsiella is becoming more popular, yeah.
Yes, but our
it's becoming more common. But I'll tell you, I'll tell you, in the lab, they have a difficulty in identifying it. Yes. In the lab, they have a difficulty, and that's why they are identifying it by polymerase chain reactions. And it's very difficult to identify. But إجمالا septic arthritis or osteomyelitis, when it occurs secondary to Klebsiella, it is less aggressive than Staph aureus.
Okay. Thank you. Okay, thank you, Dr. John. Dr. Abdelnoor, he asked you about this.
لا, إذا حدا بده يسأل يسألني. Shoot me down.
Okay, so, one question from Dr. Saeed. He asked about the management of neonates with multiple septic arthritis, multiple joint septic arthritis.
I'll tell you something. Before I tell you about the management, I'll tell you, if I get this case, I would like to commit suicide. These are very difficult. These patients have a very poor resistance to infection. We see them quite often in the neonates. We see them in the intensive care unit. And the management of each one, you have to give a heavy dose of intravenous antibiotic therapy. And you should try and evacuate whatever pus. But of course, if the patient can tolerate the surgery, if you cannot tolerate the surgery, then you have to depend on antibiotic therapy and build up the immune response. غيره. يا خالد، فرجيني وجيههم للي عم يسألوني. فرجيني وجيههم. عندك الصورة مطرح ما قاعدين. In the multifocal osteomyelitis, you have to treat it as a whole. Many times ما بتلحق بتساوي منطقة تجيك تلاقي إن a different joint is involved, a different bone is involved. You have to depend on large doses of antibiotics over a long period of time and hope for the best. This is quite common to occur in infants where the defense mechanism is bad. غيره. خالد سؤال إلك. When if you get a hip septic arthritis, where would you choose? What would you choose? Would you choose the anterior approach or the posterior approach to evacuate the pus?
The hip joint. The anterior approach.
You choose the anterior approach. Do you put the drains or you don't put drains?
24 to 40 hours.
You routinely put drains.
Yes. Now he is telling you see.
Like if you have a infection and you were given the choice where to have the infection, between the knee or the hip, which one would you choose?
Repeat the question, please.
Is عندك choice
Yes.
in an examination بيسألوك وين بتفضل يكون عندك patient with an infection, a hip or a knee?
Yes.
Which one?
The hip.
You would choose the hip.
Yes.
Why?
It is common and more prevalent than the knee, and always we meet a lot of cases of the cystic hip arthritis in pediatrics. So we did it more likely than the knee. The knee more likely to be occur in the adults rather than pediatrics.
Let's say it's gonorrhea.
Gonorrhea.
Which one is more common?
The knee.
The knee.
The hip.
What I'm trying to aim at, Khalid, is that when you have a joint where you can really, you don't have so much muscles surrounding it, the result of treatment is usually better than a hidden joint. Yani, if you look at the spine, the problem is with the spine, with the paravertebral abscesses and everything. It's very difficult to deal with these cases. And for sure, you have to do a lot of surgery on these cases. The more exposed the joint is, the better it is to treatment. This is my explanation for this. Another point, when you have a patient who has tuberculosis, and this question is being put to the fellow who asked me, how would you tell the difference between discitis and spondylitis by MRI? My question is, if you have tuberculosis of the spine, many times you get tuberculosis present at different regions of the spine with normal vertebra in between. How would you explain this?
And Dr. NTB is sparing.
You see, the reason why is that tuberculosis spreads along the anterior longitudinal ligament, just like other lesions that occur in the spine. The disc is resistant to spread of infection, especially in tuberculosis. Tuberculosis is late in destruction of the disc, while other aggressive organisms destroy the disc. They destroy it much earlier. I don't know, Staph aureus is quite common over there. when you have the psoas abscesses. So, I don't know, tuberculosis spreads to other regions. And that's why you get in regions a gibbous, while in other regions you have other regions. Now, the organism comes from the lung by means of Batson's plexus, and it can involve multiple areas also. In miliary tuberculosis, it can involve multiple areas. Now, I want to ask another question, and this is a question to all. You get infections of the sacroiliac joint. What is the differential diagnosis of infections of the sacroiliac joint? What forms of infection do affect the sacroiliac joint? One of these is typhoid fever, salmonella. It's well known to infect the sacroiliac joint. You should not forget that tuberculosis can infect the sacroiliac joint. You should know that also tuberculosis, typhoid fever, and other sorts of infection do affect the sacroiliac joint. Brucellosis is well known to involve the sacroiliac joint. So don't forget, when you have an infection in the pelvis, the sacroiliac joint is an area which can be involved in the infection. Coming to Brody's abscess. Brody's abscess can occur anywhere, in any bone in the body, but most often it involves the lower extremities. And it is known to involve the ischium, the pubis, the ilium, and you have the characteristic finding of sclerosis and the central radiolucent spine. When you have a patient where you see a lytic lesion in the ossification center, let's say of the proximal tibia, a lytic lesion, what is the differential diagnosis?
دكتور
انت اسال مين؟ A lytic lesion involving the epiphyseal ossification center. What is the differential diagnosis?
Chondrosarcoma is one.
Chondrosarcoma in a child?
No. In chondroma with calcification, with
what do you call it if you have it in a child? A cartilaginous lesion. شو اسمه؟ Chondroblastoma. Okay, that's one. Number two, what else can occur?
Brody's abscess.
Brody's abscess or an epiphyseal lytic lesion. What else? Subacute.
An epiphyseal lytic, giant cell tumor.
Giant cell tumor doesn't occur in a child.
Mature.
أنا بحكي عن الأولاد هلا.
In epiphysis, Brody's abscess, chondroblastoma in the epiphysis.
You can have an eosinophilic granuloma involving the ossification center. So this is the three differential points that we have. Now, if you have an abscess that has come out of the bone from the metaphysis, let's say of the tibia, and it has run to come into the subperiosteal region. You do an MRI. What is the sign that you will get on the MRI besides having the collection of pus in the subperiosteal region? How would you identify for sure that you have an abscess in the subperiosteal region?
soft tissue edema.
This, I said, we have it. We have an increased signal intensity, etc. How can you be sure that this abscess is in the subperiosteal region? The way you make sure of it is the junction of the periosteum with the cortex at the end of bone. تقشعوا في angle form, and this is typical of a subperiosteal abscess. So you have to keep this in mind. Okay, let me see. We spoke about osteodystomas, we spoke about gonorrhea and infants born with gonorrhea. You have to think of also eosinophilic granuloma. Eosinophilic granuloma. Tell me, what do you know about it in the pelvis and spine? خالد اسأل حدا.
About eosinophilic granuloma in the spine.
Yeah, where does it involve? Does it involve the vertebral body or the lamina? And how would you differentiate it from an infection?
Ibrahim answered that it involves the vertebral body.
Exactly.
It will make collapse of vertebra in case of vertebra plana.
Okay.
Yeah. Okay.
What is the phenomena that you have lesions healing and lesions appearing?
In case of Bajid disease, يعني mixed vein, osteolytic and osteoblastic lesions.
You get platyspondyly, you get the silver dollar sign, then بتلاقي it completely reforms and appears in another region. So this is as far as, and one of the differential diagnosis in the spine is infections of the spine, osteodystomas, infections, eosinophilic granuloma. Right. Supposing you have a patient who has multiple dogs at home, and he comes to you with back pain. What would you think of?
Abdullah.
True.
هيدا
Echinococcus. Where does it involve?
Involvement where? Anterior, posterior?
It's usually in the vertebral body and anterior. If you have pus collecting in the spine, what are 4 areas in which the pus can appear in the buttocks or lower extremity? عندك pus. عندك paravertebral abscess. What are the routes that the pus can take? I want to ask the boys, what is the triangular petit? Pus can go down, it can appear posterior over the posterior iliac crest through the triangular petit. It can go through the iliopsoas. It can go in the anterior triangle of the hip, of muscle boundaries. And all these routes are taken by various types of infection. خلاص ما يعني شو بدنا نحكي بعد. I really don't know about infection. So the important thing is to know about acute hematogenous, subacute, chronic osteomyelitis, the spine, and I have a lesson to learn on MRI to know the difference between discitis and spondylitis. Next time we'll discuss it. Okay? Nilkon, thank you very much. في بعد أسئلة؟
ثانك يو دكتور. دكتور معانا طبعا قناة على اليوتيوب اسمها Orthopedic فوكس، وممكن نرويك يعني كل محاضرتك عليها.
ما فهمت شو؟ عيلتك الصوت من عندكم ما عم بسمع.
ما ادري والله، بس اقول لك عندنا الان كويس ولا في حاجه؟ دكتور جون
عندكم
معانا شانل على اليوتيوب اسمها Orthopedic فوكس، فيها محاضراتك يعني بتجمعها على يعني شانل باليوتيوب.
طيب اوكي.
طيب شوفها يعني ممكن انت تشوفها، تقدر تشوفها.
Yes, but the point is, Khalid, what I'm doing is I'm using the books, the journals, using x-rays, using everything to create a discussion. فهمت كيف؟ هيدي هي. And that's my purpose. فهمتوا شو؟ على كل حال thank you very much. شو خالد؟
الله يسامحك يا صلاح، هذا الفيديو اللي بتحضر واحنا تكلمنا